That's your daughter. That's what I was going to say.
Yeah, they're at a reasonable time also.
So he's working.
Yeah. I told him.
That's how that might work.
No.
She's pushing the
I know.
I should have tell you there for a while. To find out about my son. Yeah,
Good morning.
I never seen either because we're on opposite schedule.
No.
Oh, good. Oh,
two of them are really friends. Just a friend.
Interesting.
oh, good. That's
Stanford. Mine's gonna be upset.
That's not hard.
Len and Andrew are pretty upset. Alright, I'll change it. Is everything's working? Everything's working. Perfect. I'll see you well. Keep doing well, yeah. I'll be here all day today.
so they had a good time.
I'll see you then.
I saw it on
Oh,
Facebook.
okay, so I didn't say what I should have said on there. They literally, so we get down there and I already pre-bought the tickets, and so we got to look at stuff in LAIV. They said we waited.
Yeah.
Pay an extra $20 and we'll go in. She puts her friend's house in front. Then it's
Finally cooled down.
You know, it's like,
Sarah. So she went and got it.
oh my
like their
God.
face and
Yeah, I think they're all the same.
and on
What is it, bigger?
they just like start they literally go like put it in a little thing and what else can we do? And the guy's like going even closer to something like and then
Frank, how are you doing? Busy morning.
And then,
it was really scary. It was probably the scariest thing I've ever been. But then it's scary so many
it's like this.
Where we're going.
Yeah.
Oh boy, oatmeal.
Game is pretty bad too.
Get any here, so I just sit over there and I get some.
Don't get too many. You do whatever you like.
Okay, I just didn't know if you had a preference.
Oh my gosh.
So you're listening, or you're just watching questions.
Just watching that.
The extra money.
No, just the audio.
Amy used to do that, right? She sits behind her headphones.
Trixie's upstairs listening.
So
Okay.
she would let us know if there's a problem.
Matt just let me know to monitor the inbox, so I can do whatever I just figured it out.
Yeah, just come and tap me on the shoulder if you need to.
Okay.
Sitting, that's fine.
Makeup and, you know, it's scary.
Yeah.
Oh,
Oh,
yeah.
I just forwarded you an email from
And then what I wasn't screaming
Reverend
at,
with
like,
Virant.
I'd look over and
I don't know if you've seen it yet. It's a screen right there.
get wet. As you're,
oh my God.
that was kind of the gross part. I was like, I just want to drink off it.
So, I mean, the story is that Tina and I sent in a request about 2 weeks
We're talking
ago.
about the one that's in,
Apart from you, Chris.
yeah, with the zombies.
Yeah, that's the same. I think it's, I haven't figured out whether that's also one of theirs too. Is that what's there?
I don't know. My daughter went there. So she's looking at her colleges.
What is she thinking?
The latest one she's looking at is like
That's what Avery was.
She'll go play soccer. She was like, there's a bunch of them.
Instead of doing the last one. Yeah, I'm not making Get this thing in. No. Where do we have? That's fine, Dan.
She's fine.
Oh, just grab another one.
Definitely was a certificate.
Or she wants UCSD. But one of these we're gonna have to send it to her camp.
I mean, if you can contact Carol and say,
She's playing, she's playing.
certificates you used to have.
So anyway,
Do you think you're?
So we got
right,
But she's really great.
Yeah, and she will. I just, you know, it's not, no, she's changed her mind very quickly. We're gonna be open about it.
I haven't been affected by that.
Oh, thank you.
And then,
So good. Hey,
Maybe.
they would ask her.
20-year-olds.
CSD.
I don't know. Stanford.
Let's go ahead and get started. Because we got a busy morning. I added a fourth speaker, so we're going to
to have to be, everybody's going to have to present quickly like a national meeting. You'll have like 12 minutes to present. I asked Dan, one of our second-year fellows, he went down for a month to Stanford to see their food allergy center and spent a month with them and sort of had a unique experience. So he's going to lead things off. So the word of the day is, in fact, Stanford. So Dan, you want to come up here? So everybody's got 10 to 12 minutes. We've got 3 other presenters to follow. And everybody speak loudly. Use the microphone if need be.
All right. Oh. All right. So I'll be brief about this since we have other more important people to talk in front of me. But I just want to. Lynn asked me to talk about my trip down to Stanford, and that was I saw at least 50 cases of anaphylaxis with the food challenge. So first off, it's called the Sean Parker Allergy Center of Stanford. It's not actually at Stanford. It's about a half hour away in Mountain View, which made my commute a lot easier since I was staying in San Jose with my parents. Who is Sean Parker? Sean Parker is one of the original .com billionaires. He was the founder of Napster. He was also a key investor in creative mind for both Spotify and Facebook. You might have heard of those. And donated $24 million to create the Allergy Research Center, as well as bench research. So just to give you an idea what this place is like, they have enough money to rent an entire floor or half a ward from a hospital. So a lot of the trouble that we have running food challenge clinics is that the hospitals really balk at you running these clinics and challenging people and giving people food that they are allergic to, which is really against the standard of care. And people say avoid, 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 and we're actually challenging people to do this. And so a lot of hospitals really don't like you doing this. Well, they said, all right, don't worry about it then. We'll take care of everything. So all of the staff there has nothing to do with El Camino Hospital. It's like a little piece of Stanford in this other hospital that's all cut off, and it's all her people. All her MAs, all her nurse practitioners, PAs, MDs are all under her.
Some people don't know who her is.
Oh, this is Kari Nadu. Under her umbrella, and as well as having a full-on research lab. There are many postdocs, PhD students, technicians, numerous people. This is a huge operation. So there are lots of food challenges. So the clinic is 5 days a week, and there's usually between 3 to 4 clinicians at each of these clinics. Each day, per clinician, there can be 8 to 10 patients a day for double-blind placebo-controlled food challenges, updosings, or screenings. So just to give you an idea of like our bandwidth, we have food challenge clinic at Seattle Children's 2 days a month. We typically see maybe 2 to 4 patients at each of those clinics, typically 2. So not surprisingly, in my first 2 days there, I saw more high-risk challenges than all of my food challenges clinics. That's like 6-7 months of food challenge clinics put together. And by the end of my time, I think I saw more patients or did more challenges than we have done in the entirety of the existence of the food challenge clinic. So they see lots of patients. And each one of those patients is on study. So every single patient that hits the door gets blood drawn, does a food challenge, does something. They're going to get blood drawn, so they have all this stuff on every single person that comes in through that door. And it's truly a multidisciplinary approach. So, like I said, everybody's on a descriptive study with blood drawn, and their laboratory is state of the art. So they have next-gen sequencing, genomics, DNA methylation with the methyl-seq, that's post-translational modification of things, microbiomics, proteomics, as well as bioinformatics people, just who specialize in this stuff to deal with this tremendous amount of data. One of the techniques that they're kind of known for is something called CyTOF. It's a new type of phenotyping. And what basically this is that instead of, you've heard of like David talking about typical flow cytometry, where you have antibodies, that bind to the cell, and these are, and typically in typical flow cytometry, this is with cytochrome, that you put through a spectrophotometer, and you can measure the different bandwidths of light. In this case, what they use are heavy metals. So as many metals as you can have as many antibodies attached to any specific marker that you want. And it uses mass spectrometry to differentiate between the different heavy metals. Oops. So you can use time of flight to determine this. So instead of being limited to 5, 6, 8 different antibodies, you can do 15, 20, 40, 100 different antibodies. And you can also do it on far fewer cells, too, as well. So it's an extremely powerful type of phenotyping machine that we don't really use. So some of the studies that are going on currently at Stanford, one of the ones that I kind of came down for really was the multi-food OIT with omalizumab, or MTAX. And it's a 60-person study, multi-site, including Seattle, but it's dotted all over the country. It includes age range from 4 to 55. And it's treatment with omalizumab for 2 months prior to start of oral immunotherapy, with up to 2,000 milligrams of total IgE who's eligible. Okay, so their dose of Xolair is much higher than what I've seen typically done. So somebody with a weight of like 50 kilos with an IgE of like 1,900, they're going to get 600 milligrams of Xolair Q2 weeks. So the whole ton of Xolair. And the oral immunotherapy is unique in this case because it uses up to 5 different foods. So instead of just peanuts or just milk, like in most studies, this is up to 5 different foods. So it could be peanuts and the tree nuts, so cashews, pecan, walnut, almond, hazelnut, as well as egg or milk, and any combination thereof. So it could be up to 2, as low as 2, or up to 5 of those, and with the goal to get around 2,000 milligrams of each allergen. Now, an interesting thing to tag on to the end of the study is a tolerance study. At week 30, subjects are then divided into 3 groups. The A group is continuing on with each allergen at 2 grams. The B group is to drop it down to 300 milligrams, and the C group is just placebo. And this is done for 6 weeks, and they're brought back in for a double-blind, placebo-controlled food challenge to see if tolerance has been lost or persists, and how much has been lost.
Have they gotten anybody that far
Nope.
yet?
Nope.
No.
Not yet. We're actually one of the farthest sites along, so we'll see. We're getting there. Our first one, I think, is in week 24, 25, something like that. So they're getting there. But we were further along in terms of our recruitment than they were. And just of note, we actually have a couple more slots left. They gave us another 5, so we recruited our 10, and we were at 12, so we have 3 more spots available. So if you have anybody who would be a good candidate for this, let me or Dr. Tillis or people at Asthma-COPD know, and we'll see if we can get into the study. Other clinical research, this is stuff only at Stanford. They have an OIT trial called POISE, which is a peanut OIT. And this is looking at endoscopy. So it's peanut OIT plus endoscopy. This is kind of to examine eosinophilic esophagitis. So they're going to do a baseline, during, and post endoscopy. And then there's some interesting things that I got involved with while I was there. For whatever reason, in the months of July and August, there was incredibly high epi use, much higher than it had been in the past year and a half of this study. And they really were kind of puzzled why. I helped do the down analysis and something after that was going to go to the Quad AI. We looked at environmental causes, whether pollen counts were really high. Actually, pollen counts were actually lower in July than they were in May. Temperature was actually cooler those times of the month. So it's kind of hard to say what exactly it was. It could be that it was summertime and they were just more active. It could be it, yeah.
Did they look at a subset like reactive to grass antigens?
Yeah, we divided that up too. Looked at that. I didn't find any correlation for it. Yeah. There's also the phase 2 and phase 1 multi-OIT studies. So before they started MTAX, they actually had a placebo-controlled Xolair, but it was so good that they decided to, with this trial, just put everybody on Xolair. So just to give you an idea of protection of Xolair, so in the OIT of poise with just peanut, it takes these guys maybe a year-ish to maybe a little less than a year to get to full maintenance therapy. With Xolair, for most patients, they can get up to full maintenance within a month or two, like 8 weeks is usually kind of it. So I mean, it's a much more accelerated treatment. In the last study, something that I've become involved with is the twin study. It's specifically the RO1 is looking at asthma and studying how the immune system and environmental pollutants and exposure to secondhand smoke, both in utero as well as after they're born, particularly in asthmatics. But an interesting subset of these patients claimed food allergy, which is a project that Kari asked me to take on. And so I took on this cohort and basically brought them in to screen and challenge them to confirm food allergy. So not based on IgE level, not based on skin test, but actually you have to react in front of me. And so the twins were screened with allergy skin prick tests and graded challenge to allergens with up to 2 grams of total allergen. And so from this study, we now have several concordant monozygotic twins. Interestingly, all my concordants all reacted at the same food at the same dose. It was really interesting. And then I have a couple sets of concordant as well as discordant dizygotic twins as well. An interesting set, I have a set of triplets. 2 of them are monozygotic and 1 is dizygotic. The monozygotics both have food allergies and react at the same level, and the dizygotic does not. So we're currently doing next-gen sequencing and site-off and microbiomes from the stool and all these twin pairs. And of note, this is going to be expanded up to the Seattle area. We've already had this. We've already had the contract signed and everything, so they're going to be coming up here. And so it's a collaboration between Asthma Inc. and Stanford. And so if there are any twins that you're aware of in your practices and that have known food allergies, I would like to see them. So it's interesting to get hooked up with this with Kari and Kari Nadeau and all this stuff, because if they one of the benefits of joining this is that if there's future OITs that are going to be or immunotherapies that are going to be available, they'll be kind of top on the list to be included on it. So there is some benefit to the patients as well. Okay. So the ones I really want are the discordant monozygotics. So one twin, not necessarily different, but I want one twin with allergies and the other twin without food allergies, identical. I have one maybe that is on the pipeline. I was promised another one, but the kid was actually not allergic to anything. So that's it. So nice and quick. Any
And
questions?
how young do they go in the subjects for the kids?
For the multi-food, 4.
4 ages.
Sounds like an incredibly productive. You did all that in 1 month?
Yes.
Shows you what money can do. 24 million bucks.
Yeah. That's the other thing I learned. $24 million is helpful.
All right.
So I'm
Andrew, go ahead.
I'm Andrew Parker, one of the first-year fellows. And this is a little presentation about asthma-COPD overlap syndrome. So there's a little bit of background. This is a asthma and COPD, so chronic lung disease is something that affects a lot of people worldwide. And there's some thoughts that a good percentage of those people actually have features of both asthma and COPD. And despite us sort of learning the typical phenotypes in medical school, we sometimes see patients in our clinics that don't quite fit that typical picture that we see. And so ACOS has sort of emerged to characterize some of this overlap. There's some question about whether we're seeing sort of various phenotypes of each specific condition. Sort of, we're not clear what the primary condition is. And it's not quite clear what the implication of therapy are. So a recent review article in the New England Journal sort of questioned this, basically how to determine the diagnosis. Is this true asthma, true COPD, or a mix of both? And how should clinicians tailor treatment? So these are just the definitions based upon GINA and GOLD, the sort of organizations that define these. And one thing that you can sort of see in blue is that there's overlap even based in their definitions, the defining features of things to discuss chronic inflammatory lung disease. They talk about exacerbations, recurrence of the symptoms that we attribute to both diseases, and talk about airflow obstruction. Even in asthma, which we think of as sort of the definition of being reversible, we see right in the definition that they sort of temper that with using words like variable and often reversible. So there definitely is some overlap features in both of these. We think of the various features of the disease, whereas in COPD there's sort of two components. There's the chronic bronchitis, which is more airway inflammation, or an emphysema, which is more distal, more alveolar inflammation with destruction of tissues. And asthma we think of as it's affecting the airway only. The kids we think of asthma sort of as being a childhood disease and frequently accompanied by allergies, whereas COPD begins later and is likely, we most commonly see it in people here who have been exposed to tobacco, or in sort of the developing world who have been exposed to like cooking, smoke, and pollution. And we think of the type of inflammation sort of being different. So in asthma we think of it as more as an eosinophilic or type 2 helper cell inflammation, whereas in COPD we think of more of a neutrophilic and CD8 positive inflammation. And so when we see people in our office, we sort of come up with a picture on our head, and a picture that's sort of been developing since medical school. And I don't know, at least for the picture on the right, that's what Google thinks somebody with asthma looks like. And on the left, we see that classic sort of the blue bloater and the pink puffer that Frank Netterso provided for us here. This article shows a little bit. They didn't talk a whole lot about the sort of underlying pathophysiology, but they did show this sort of picture here without much explanation, showing sort of the differences in asthma and COPD. So asthma, you get a lot more hypertrophy of smooth muscle around the bronchi, and you get luminal narrowing because of that with inflammation. Whereas in COPD, they focus more on, you see the inflammation and sort of mucus secretion causing the airway narrowing, and then destruction of the alveoli from that inflammation in an emphysematous process. That should show a little bit about the natural history of disease. And again, they didn't explain it well. And part of this I'm not quite clear on. They talk about how in COPD there's sort of a baseline defect in FEV1 starting as early as 25, and I'm not sure that's really the case. We tend to think of it developing a little bit later. And I think we've all seen some folks with asthma who have non-reversible changes in their FEV1 early as well. But one of the interesting points that they show here.
You got a pointer there.
Yeah. Is it just a touch
The
of
mouse.
mouse? So one thing that they do show is that when people exacerbate their COPD, they tend never to get back up to their baseline. So you can see here, once they exacerbate here, the best they can ever do is get back here, and same here, they can only get to here. And you can also see the width of the exacerbation is longer, so it takes much longer for them to bounce back, sort of until closer to the end. Whereas here with asthma, most folks come back to their baseline FEV1 after an exacerbation, and their FEV1, and the time course of their exacerbations is much shorter, but they end up at sort of the same point. So some of the hallmarks of disease we think about, especially sort of in terms of asthma, we think of bronchial hyperresponsiveness, reversibility of the obstruction, sort of an allergic phenotype, and airway inflammation. And what this article basically goes through is, and I'll go through in a moment, is it counters each of these, that these can be found in COPD as well. And what do you label those people with COPD? Do they have they have sort of asthmatic components to them as well, or is that just part of the underlying COPD? So for the hyperresponsiveness, we see people with asthma sort of having various triggers, whether that's cold or exercise or allergens, dander. And the hyperresponsiveness is sort of mediated by the reductions in airway diameter and the increased wall thickness and the reactivity of their smooth muscle. And when you biopsy those people who are particularly hyperresponsive, we see that they have even more eosinophilic inflammation compared to your sort of standard kid with with asthma, and that's why steroids work so well in these folks. But there's a lot of people with COPD who are also pretty hyper-responsive to similar triggers to allergens, colds, and exercise. And when you biopsy those, in addition to sort of the usual cells that we find in the COPDers, we also see increased eosinophilic inflammation. One thing that's interesting is that bronchial hyperresponsiveness portends a worse prognosis for the COPDers. They actually have more of a decline in their FEV1 compared to their COPD counterparts who don't have such bronchial hyperresponsiveness. And in smokers, it's even amplified further. In terms of reversibility, we sort of classically think that asthma is fully reversible. But we do know that some with long-standing asthma aren't fully reversible. And they've seen a few studies now that have looked at reversibility in COPD and show that there's a good percentage of them that actually reverse their obstructions as well. One thing that's interesting, though, is those that have reversible obstruction in COPD don't necessarily have less severe disease, and their outcome is the same as compared to those who don't reverse. We think of sort of this allergic phenotype and asthma sort of being married. You see a lot of kids with coincident disease, but it's prevalent in COPD too. Depending on how you measure it, they've done some studies that show that as many as 30% of people with COPD have coexistent allergic rhinitis. And some of those same studies have found that sort of inhaled steroids are not sort of the go-to in COPDers, or at least first-line therapy, but they find in those folks that they actually tend to respond much better to steroids than the typical COPDer does, compared to those without ATP. And then airway inflammation. So I mentioned before about the different cell types that we find when you biopsy these folks. But they've done some studies that show that patients with really severe or sort of later onset asthma have more neutrophilic invasion than what would be expected. And they find in people with COPD, I didn't see any biopsy studies that they were citing. They were at least large. But they did a lot of sputum studies, and they showed that even when they control for some of the features that I discussed that demonstrate increased eosinophilia, there's a subset of people with COPD who have an eosinophilic presence, and those folks tend to respond better to steroids like those with asthma. So they present this table as sort of the classic, sort of 4 examples. The first 2 are sort of the easy asthma, easy COPDers, the ones that the pictures that you have in your head from medical school. And they show a little bit later, the final 2 are the ones that have sort of a blend of features. Both of them have sort of chronic dyspnea. Both of them here are the same age. Both of them here have the allergic phenotype. But some of them, there's variability in terms of the reversibility of their obstruction, whether they're hyperresponsive or not. So where does this really leave us? If both diseases are sort of separate entities and they have different sort of underlying pathophysiology, what do we do with those that we're seeing sort of similar clinical phenotypes? There's been a few papers that have tried to describe these phenotypes. And I think one reason is because, especially for asthma, we have a pretty rigid treatment regimen. It's sort of a one-size-fits-all step therapy guide that's provided to us that doesn't necessarily take into these considerations. More in 2010, sort of about 5 different clusters of severe asthma, at least. About 2 or 3 of those clusters sort of having kids that have the allergic phenotype that demonstrate variable reversibility, and 2 other clusters which are sort of adult onset asthma. And then there's similar clusters that have been presented in COPD, and here's one of them here. This is a paper by Marsh in 2008 that does this Venn diagram consideration of chronic lung disease. And he shows that there's a portion of people with sort of features of chronic lung disease, whether it's cough and breathlessness, that have airflow obstruction at all on testing. And he shows here that there's a portion of these that we could call asthma, typical asthma, that have the complete resolution of their airflow obstruction. But there's 3 other sets who have that are considered to have asthma that don't have necessarily complete airflow obstruction. He doesn't really go on to discuss. This is all just clinical phenotypes. There's no underlying pathophysiologic phenotypes. So, where does this leave us in terms of therapy? And this was not as heavily discussed by the paper, mostly because the professional societies, the GOLD and GINA and NHLBI and everybody else, haven't really provided any guidelines. In fact, this ACOS or the consideration of people that sort of share multiple phenotypes has not really been considered by the professional organizations. I think for providers, for physicians, the treatments blur the lines in the first place, and it's because the same medication arsenal is used for all these patients. We use steroids, we use the long-acting and short-acting beta agonists and muscarinic agents in both asthma and COPD. What they recommended in this paper, and this was not data-driven, but they thought that if there was any component of asthma, whether they're an asthma primary or sort of a COPD with some asthma-like features, then it's worthwhile to use a steroid. And they remind us not to use a long-acting beta agonist alone. In COPD, if there's any asthma-like features, as I said, again, if you find anything like reversibility, or if you happen to look at their sputum, to consider using a steroid. But they went on to say that a lot of the future therapy may be best directed by having a better sense of the underlying physiology of the different phenotypes. And that, for instance, there's been some studies about using macrolides in asthmatic patients who show more neutrophilic invasion, or which they sort of see as the older asthmatics, or using Xolair in COPDers who have more of an underlying allergic type.
You did a fine job. I'm not sure that paper is helpful.
That's
The way I look at it, maybe that overlap group is
there's a problem.
Yeah, the problem.
There was
They take atopics and they start smoking, and then that's maybe what separates one group from the other. But the big therapeutic thing that always disturbs me with this group is one group it's not safe at all to use a long-acting beta agonist, and in the other group you can start that as primary therapy. So we've got a major conflict there. Frank's got some totally different, interesting stuff to present.
There was one long-term epi study that showed that the highest prevalence of developing emphysema was in a smoking asthmatic. So it's always important to counsel our patients to smoking cessation.
Remember those decreased FEV1 curves? This is normal, this is an asthmatic, this is a smoker, then this is a smoking asthmatic.
All right. Well, both of these topics are actually from the August JACI. You may have seen. The first actually is a deluge of free back-to-back-to-back papers, which cover a lot of the same concepts, but are pretty interesting and have some potential utility for, as I'll show you, screening certain ethnic groups that you're about to put on certain medications. And then a sort of tongue-in-cheek article from the UK and Australia suggesting that maybe we should change our guidelines in the US as far as safety of the live attenuated influenza virus use. So this is just a little cartoon to show you some of the current concepts for T-cell mediated drug allergy, and I'll show you sort of 3 different models that are postulated, and actually all 3 of these articles at least agree on postulated mechanisms, and they give some examples. The middle mechanism mainly in animal studies, but some actual clinical examples of the various types of potential reactions. So on the left side of the cartoon, you can see what should happen if T cells are presented with a self-peptide through T regulatory pathways, those cells should be deleted, and you should avoid autoreactivity. Model B shows an example of what can happen, and this can happen with some penicillin and sulfa reactions, much like actually IgE-mediated penicillin reactivity, where the drug actually can bind to a self-protein, and as that sits in the context of an HLA molecule, presents a different antigen, so T cells can actually react. And it's been shown that this requires separate activation of the innate immune system in creating a reaction. The second model is where the drug can actually bind directly either to the HLA molecule or the T cell receptor, or a combination of the two. And this has been shown in some animal models with quinolones. And a key aspect here is that this is independent of any innate immune activation. So this can happen very rapidly, for example, acute liver injury and so forth. And then a third potential mechanism, and I'll show you some further examples here, is where a drug can non-covalently bind to to a deep pocket in the HLA molecule, and then a self-protein actually can bind to that, creating a third structure which the immune system does not recognize anymore as self, and that can also lead to a T cell mediated reaction. This also requires processing. And I'll show you several examples. There's actually several of the reverse transcriptase inhibitors that can cause drug-induced injury in this way. And what's intriguing is there's various isoforms of HLA molecules, and it turns out certain ethnic groups with certain HLA molecules, 95% of the population has that particular type of HLA. So with a certain drug and a certain ethnic group, this is a great setup for disaster, potentially. This is a very busy little table, but just to show you some examples of specific HLA types with specific medications that, in particular, in certain ethnic groups, are a pretty much guaranteed setup for an adverse reaction. And the third article, and I know this is a little probably hard to read, but I've summarized some examples for you in the next slide, where in certain populations, for example, you can see carbamazepine in a large part of Southeast Asia, particularly Han Chinese. If they have this specific B1502 HLA allele, it's very likely that they're going to get an adverse Stevens-Johnson or TEN-like response to carbamazepine. And just some other examples. And I've just highlighted a few, if you go through that table, a few that think of this sort of like doing a genetic test for celiac susceptibility with a DR2 and so forth. Not a very specific test, but in particular ethnic groups, if you're contemplating a certain drug, if the patient in question has the particular HLA type, it's very likely that they're going to be at high risk for an adverse reaction.
Frank, I've never understood what the nomenclature about HLA, things like 5701. What does that mean as far as the amino acid sequence of the HLA receptor?
Yeah, to be honest, I don't know.
David, you must know.
Can you help us with that?
Thank you, remind yourself. So the different alleles, and within there is more than that. So there could be other. It can continue after that. As people are doing more and more deep sequencing, they find different variations. So some of them more significant, some of them are not. Just the number of the alleles that they keep finding on and on. I think right now...
It just refers to the exact structure of their...
So initial structure and then variation within the same structure, and then within this structure there will be other numbers after that suggesting if it means anything or not. Because if it will be a silent mutation, that mean anything. But you can get more and more variation. So it used to be HLA, ABC, DRDQ, and now ODP. And for each of these 2 copies, so 12 different variants, and now I think it's in the range of maybe 2,400 or 300, so it keeps going on. So as far as doing more and more sequencing.
So it's complex.
I think it depends on the level of the match that you're looking for. So this will be the initial way to divide them, different allele with major differences. And if you look for something else, in transplant, for example, you need to be more specific. So yes, it's complex, but depends on how deep you look.
Teasing you.
But I think part of the point of the article is, for example, you'll see Han Chinese mentioned several times, that when they have this HLA, it is almost always in the population the same HLA molecule. Whereas in other, and perhaps in other situations, slight variation. So it really has the degree to which that drug can bind to the cleft in the HLA. It's like a perfect fit. And perhaps less severe reactions might be a slight variation where the binding's not quite as good. So you don't get quite the tenacity of the reaction. So again, a situation where in a specific patient group with a specific drug that you have in mind, or a patient who's on that and you have a reaction, you can often really pin down the culprit using an HLA screen.
Frank, when you ask, can you ask a patient, are you Han Chinese? Would a patient know that they're Han? What's the... No?
Yeah,
I'll ask
they
Sydney.
they would. It's the main kind of, there are just a little bit more minority groups in China, but most of Chinese people are Han Chinese.
Oh, okay.
So they would know they're minority, and if not, then...
It's part of the education. You have to ask them and then check that. I think if you
In
follow
China?
the guidelines. No, in neurologic, if you want to start somebody on carbamazepine.
Oh. I've never asked.
Repeat that dialogue for our audience, outside audience. Basic is people would know their ethnicity accurately enough to know that they're at risk.
Right. Yeah. Well, if they don't know their ethnicity, they're likely Han Chinese. Like if they were minority, they would be aware of that.
Yeah. Having said that, you can obviously looking at European here, that's pretty vague, and the article didn't really go into are there actually regional European areas that are more relevant than others.
Frank, before you move on,
Yeah.
Has this shown up in the medical legal literature yet?
Yeah, that's a good question.
That these people with the dress, Sir Stevens Johnson, and then he said, didn't you know allopurinol is 100% likely to cause this? I can only imagine this is going to be a problem.
It probably will now.
And the insurances won't pay for the screening, so then we're going to get burned with the results.
Yeah,
so.
exactly.
Okay.
Like you should have checked that.
Yeah.
Except it was $1,000.
Yeah.
All right. So the second topic that I pulled out is looking at the potential utility/safety of live attenuated versus inactivated influenza vaccine. And the article, this is sort of a backdrop for what I'm going to talk about, but the article is specifically also looking at egg allergic children. And as I'll show you, not surprisingly, a high percentage of them have significant allergic rhinitis and asthma as well, which is also some of the controversy in using the attenuated vaccine in young children. So this was an article, sort of a landmark article about 8 years ago in the New England Journal, where they looked at, I believe it was close to 3,000 children, comparing the relative efficacy, and this was from essentially the first year of life up to age 5, looking at the relative efficacy of the vaccines. And as you can see, there were 55% less cases using the live attenuated nasal vaccine. It turns out, interestingly enough, above age 8 or 9, if you look at this, the differences are much less. And nobody, I don't think, really has a great explanation. Everything from, kids this age have even more URIs, maybe actually having inflammation in your nose is a good thing as far as responding to the nasal vaccine more avidly. I don't think anybody knows. But this is part of the recommendation for potentially differentially using the flu mist in younger kids. However, that study also showed, if you look at 6 to 11 month olds, you can see medically significant wheezing was increased in that age group. Now, if you look at the bottom, this was up through a half a year after giving the vaccine. So, whether that's cause and effect is questionable. The other interesting thing was hospitalization for any cause, which I would say by definition, it literally was any cause. Not sure what to make of that, but again, this certainly got the attention of people that give these recommendations. If you go even further, which this slide doesn't, those trends continue until about 2 years of age. So this led to the recommendation is you don't use the live attenuated vaccine in kids under 2. If you stratify the data even a little more, there's some very slight evidence of increased wheezing up to age 5 at all, especially if the child's had any wheezing in the year before. It's very subtle, but that is also leading to the current recommendation of not doing this in kids under 5 that have had any asthma in the last year. And as I'll show you, that may not be really the correct response. So the study in question is this one, which, as I said, is from the UK and Australia. A much smaller study, almost 300 children with cumulatively over 400 doses. This was age 2 to 17, with a median age of about 5. Interestingly enough, a very high percentage with prior egg anaphylaxis. It wasn't really well described, how long prior, nor their current egg allergy status, so that was one potential caveat. A very high percentage had asthma, very consistent with the atopic march story, and half were on controller meds for asthma. So this group was sort of postulating this might be a unique way to look at not only of the safety of the vaccine, but also in kids with rhinitis, asthma, and egg allergy. And essentially what they found, and their definition of a potential allergic event was something happening within 2 hours after giving the vaccine, which is probably generous. And as you can see, there was 9 adverse reactions out of the total number of doses. 7 of those were acute rhinitis. 1 was local urticaria on the face, and 1 was abdominal pain, which was questionable whether that was truly related. So generally, no major concerns about allergic events. And as you can see, certainly no systemic events whatsoever. And the authors point out, and all of these are significant, or shall we say non-significant, there's really no risk factors for any of the adverse events. In other words, the age of the patient, severity of egg allergy, prior flu vaccine, tolerance to baked egg, etc. Now, one, I think, potentially important caveat, the 4 lots that they used for the flu mist in this study had an extremely low ovalbumin content. In other words, if you look at the allowance, that's a factor of 4,000-fold potentially higher that it could have been in the vaccine. So the question is, had it been a lot where there was more ovalbumin, would there have been more adverse reactions? But, given that caveat, their conclusion based on this study is that it's a safe approach to use in egg allergic children. And as you saw, nearly half of them had a history of prior egg anaphylaxis. It is safe to use, and basically their definition of control was no active asthma within 6 weeks. So not going back a full year, but controlled asthma within 6 weeks of giving the vaccine. In other words, if you weren't controlled, you weren't allowed in this study. And their suggestion is that perhaps this really should be reconsidered as first line, given the efficacy of the vaccine and apparent tolerance in these kids going down to 2 years of age. They sort of left it open that perhaps there is something unique in younger kids. But obviously, given the potential utility of not having to give shots and the potential better efficacy, certainly food for thought. And I don't know if similar studies are ongoing in the U.S. again to try to more firmly answer the question.
They've cut the recommendation for avoiding exposure down to 1 week, down from what used to be 2 or 3 weeks. Did they comment on that with these new viral?
They did. Not that I saw.
Is this the guideline in the UK and
It is.
Australia? That's what they do.
It is.
How does that level of ovalbumin compare with the injected dose?
Well, again, I'll go back. I'll show you that the maximum allowed, this was in the UK, and that's now true in the US as well. So it has to be under a couple micrograms. The typical, like the vaccines that we use for injection are on the order of a couple micrograms, which is much less than some of the vaccines had 10, 15 years ago. They had 50, 60, even 70. So it's a bit like the latex story, I think. The manufacturers kind of cleaned up their act a little bit, not wanting to be the poster child for the most ovalbumin. So food for, obviously it doesn't change the recommendations here, but something to think about. And I don't know if those, I would hope that somebody's studying that here to prove a similar thing that might lead to changes.
All right, excellent. We got one more speaker cramming a lot of information into one morning. Paul McBride. Another controversial subject here, non-celiac gluten sensitivity.
I sort of read this because it seemed like I'm getting more and more people coming by now that say, I'm allergic to wheat, and then you can't prove anything to these people. So I sort of saw this article as actually a relatively good review. These two authors, it was in the Mayo Clinic Proceedings, which usually I toss, but for some reason I looked at this one. And they actually did a pretty good job of evaluating all this data. So non-celiac gluten sensitivity, a clinical term used to describe GI or extraintestinal symptoms associated with gluten ingestion after you've excluded celiac disease and wheat allergy. And there's no biomarker for this, so it's strictly a clinical diagnosis, which sort of opens it up for our interpretation. And it needs to be separated from food intolerances because they're mechanistically different issues. So gluten-related disorders are typically classified by immunologic mechanisms. So celiac disease is autoimmune, wheat allergy is allergic, and non-celiac gluten sensitivity is not autoimmune or allergic. They think it's innate, but again, it's not a well-defined clinical entity quite yet. So when these people present, they usually present with GI or extraintestinal symptoms with gluten ingestion. The prevalence is really unknown. All the clinical features overlap with celiac disease and wheat allergy. And again, the pathophysiology is thought to be due to innate mechanisms, and there's no evidence for autoimmunity or antibodies against wheat. And in order to even contemplate this diagnosis, you have to have excluded celiac disease and wheat allergy. So the patients come in usually with GI symptoms that occur within hours or days of gluten. All the symptoms resolve on a gluten-free diet. And then the diagnosis is made by elimination of symptoms on a gluten-free diet, then recurrence of symptoms following gluten challenge. And again, since there's no biomarkers, this all has to be done with patient history and patient symptom responses. So food intolerances or malabsorption are non-immunologic reactions that occur when nutrients are not digested properly or completely because of the lack of necessary enzymes. And we all know about lactose, but then there's the FODMAP group of chemicals, fermentable oligosaccharide, disaccharide, monosaccharides, and polyols. And these are all classified in this sort of heterogeneous group of FODMAP foods. So in 1980s, the first written report of this non-celiac gluten sensitivity with chronic abdominal pain and chronic diarrhea, and these patients resolved on a gluten-free diet, and as soon as they were challenged, their symptoms came back. Then there's not really a lot of really interesting articles in the literature until about 25 years later, when Wanschnaff, however you say that, I don't know, described patients with diarrhea-predominant IBS who improved on a gluten-free diet in the absence of celiac. And this responder group were all HLA-DQ2 positive patients that had IgG antibodies to tissue transglutaminase or gliadin, not IgA. So they separated out on the sense that there was a biomarker in that group. Then that person, they did the first double-blind placebo-controlled trials in IBS patients who described a history of improvement on gluten-free diets, and they were randomized to either a gluten-free or gluten-containing diet for 6 weeks. Then they were reevaluated and crossed over. And 68% of these patients reported worsening of their pain, bloating, fatigue, and diarrhea while on the gluten-containing diet that was not present on their gluten-free diet. But there are no differences between the groups with respect to HLA-DQ2 or DQ8 at any of the study points. Then you start looking at randomization studies, and Vasquez-Roque, who's the author of this article, they randomized patients with IBS to glucose-free diet or gluten-free diets or gluten-containing diets for 30 days, and they measured stool frequency, colonic transit time, and they came up with a very interesting way of measuring intestinal permeability with a weird laser thing where they could actually show permeability of the mucosa. And the people on a glucose or gluten-containing diet had increased stool frequency, increased small bowel permeability, and they were mostly HLA-DQ2 positive patients again. The patients on the gluten-free diet showed no changes from baseline, and most of these patients had already been excluding gluten on their own before they even entered the study. So these two studies, the B person I can't say and Vasquez-Roque, both suggest that this non-celiac gluten sensitivity exists, but there's a disagreement as to what's the cause. Is it either gluten or is it one of these FODMAP foods? So the B person in 2013 did a double-blind crossover study in 37 patients with this non-celiac gluten sensitivity and IBS. And all the patients got 2 weeks of the decreased FODMAP foods and were then randomized into one of three groups. One group got high gluten at 16 grams a day. The second group got low gluten, 2 grams with 14 grams of whey. And the control group got 16 grams of whey and 0 grams of gluten. So the GI symptoms all improved on the FODMAP diet patients, but the GI symptoms did not reoccur when gluten re-exposure occurred, but it did occur when these FODMAP foods were reintroduced into the diet. So they're postulating that this is a real entity, but gluten isn't the trigger, and they're wondering if it's these smaller molecules in this FODMAP compounds that are causing the symptoms and not gluten itself. So the laboratory studies, you can change the weights of the stools, you can change intestinal permeability. So these can be measured objectively, and they're using that as a way to make a more objective diagnosis instead of just being a clinical diagnosis. So the best data on this non-celiac gluten sensitivity comes from the National Health and Nutrition Examination Study in 2013. And they studied 7,700 patients from 2009 to 2010 and found that 0.55% of them were on a gluten-free diet for the time that they were answering the questionnaire. And this is people, most of these people are on gluten-free diets without any medical input whatsoever. They just put themselves on these diets and then they say they feel better. Then they had a second study, another NHANES study in 2009 to 2012, and found that that number had actually increased to 0.8% of patients. And all these patients had no diagnosis of celiac disease, but were on a gluten-free diet anyway. So they had brought that either from the naturopathic input or from just their own personal preferences. And then 82% of the patients on a gluten-free diet started themselves on that diet before being given any medical advice. So these double-blind controlled studies in patients, they've done 3 of them now with IBS. It says that 30% of IBS may actually be this non-celiac gluten sensitivity. But again, the studies, it's all clinical, so there's not really a marker to follow. So if you look at the pathogenesis, it looks like this disease triggers an innate immune response because you can see upregulation of a lot of different toll receptors. And in celiac disease, you don't really see that change at all. Now the question is this disease a true entity? The question is this disease a gluten-sensitive problem, or is it one of these FODMAP foods that's causing the triggering? So there's more and more studies now that are looking at these oligo and disaccharides and monosaccharides as opposed to gluten. And this confocal laser endomicroscopy, they're some pretty neat pictures of what it looks like, but with my computer illiteracy, I couldn't put any of them into this for you. So they found that in 22 patients out of the 36 with laser and endomicroscopy, they could show intestinal leakage after gluten exposure, but then almost exactly the same number had the same findings after ingesting one of these FODMAP foods. So it's basically a 50-50 answer there, whether it's gluten or whether it's one of these oligodisaccharides issues. And then there's another question that there's natural amylase and trypsin inhibitors found in wheat. And these are found intact in wheat after it's been digested. And they're contemplating whether that could be actually a trigger in the gluten patients instead of the real gluten molecule, but one of these amylase trypsin inhibitors could be doing it instead. So if you look at these 3 diseases, or 3 entities, depending on how you want to approach it, with celiac disease, the symptoms are days to weeks after exposure. With non-celiac gluten sensitivity, it's hours to days, and in wheat allergy, it's actually minutes to hours. And pathogenesis, celiac, autoimmune, non-celiac, innate, and wheat allergy is allergic. The HLA restrictions, celiac disease is restricted to HLA-DQ2 or HLA-DQ8, and the other 2 are not restricted. In celiac disease, you almost always have autoantibodies, and in the other 2 entities, non-celiac and wheat allergy, they're always absent. Enteropathy, it's celiac disease almost always positive, and in the other 2, it's always absent. And then intestinal and extraintestinal features, they are the same with all 3. And in complications, there's a lot of comorbidities and long-term complications in all the 3 groups, but the 2 are long-term, mostly survivable, and then the 3rd is anaphylaxis, is their long-term concern. So if you look at this, this is probably a clinical entity with GI and extra GI features, but you have to exclude celiac disease and wheat allergy before you can even contemplate this diagnosis, because the 3 diseases overlap so much. The pathogenic evaluation of these, we don't really understand what's causing this disease in it of itself. There is no biologic marker, so it has to be a clinical diagnosis. But, this is a sort of fair game for these alternative test patients that come in and say, I have this disease because I have all these things positive. And you can usually talk your way out of most of them, but unfortunately some of these tests are probably going to be important down the road. And we really need to find a biomarker so that we can separate these 3 diseases, but so far there isn't one. And that confocal laser microscopy doesn't sound like that's something we're going to be able to do in our offices anytime soon. But it is a pretty cool test. So I don't know how many of you see this and patients coming in saying they're gluten sensitive, and then you work them up and you get nothing. And then I think this is what we're going to be left with, is this disease. And then whether you put them on a diet or you encourage them or you try and discourage them, I think that's where your clinical judgment is going to have to be your guiding force, because we don't have a test to answer this question. But I see these people, I think, every day I'm seeing one of these people now. And it didn't seem to be that way in the past, but it just seems to get more and more popular diagnosis for the patients that come in, and then we exclude everything we know how to exclude. So the question is this what we label them with, or do we just say we don't know what you have? So part of this is a question on my part, is how do you manage these people? And the second question is, does it really seem like it's a clinical entity that we should really identify as such? So that's why
we see people every day who put themselves on this diet and swear normal people who say they're much better, which there's definitely some people with a real entity that clearly get better by modifying their diet. I agree with this paper that there is something to it.
Well, that's why I thought this was a really good review article and presented the data very objectively, because usually there's zealots on both sides of this question, and I don't usually agree with the zealots either way, so this is sort of a middle ground that maybe there is a clinical diagnosis, but it would be really nice if we had a test that could tell us what it is, other than some third Star Wars laser issue that you can do and do it in your lab. But since the new Star Wars is coming out in December, maybe we'll have that.
So when people put themselves on this diet and just follow whatever's on the internet or something, do they wind up avoiding the FODMAP foods as well, even coincidentally?
Yeah.
Most of the time they're sort of coincidental like that. And again, when you challenge, you have to challenge with specific weird chemicals to challenge the FODMAP foods. Because there's lots of different oligosaccharides that don't come from wheat, they come in other grains. It's mostly grains though that have them. And when you challenge them, you have to be able to follow their symptoms, because again, we don't have any, you can measure stool volume for 30 days, but I'm not sure our lab would do that, so I don't think that would be anything outside of research. But these people, they're adamant that they're sick and then they're better, so I guess we just have to follow their symptoms, which is what I came up with.
To make it more complex, if they're taking themselves off gluten, then you have a hard time making any diagnosis.
I don't know how long you have to be 100% gluten-free for your antibody test to go negative. I've read anywhere from 3 months to 3 years, so I don't know the answer there. But yeah, but these people may not be able to be diagnosed anyway. I mean, they may have come in with, they've already figured this out. But these FODMAP foods, I mean, they're in so many different things. It's not just wheat, that's for sure. But that's the main grain that we eat, unless people switch away from it and go to one of the alternative grains. So all these foods contain all the same chemicals, which is what's frustrating. Because then when you challenge them to wheat, you're actually challenging them to all the oligosaccharides and the disaccharides and monosaccharides as well. So you have to chemically split the molecule and challenge them separately to each of these to prove which it is. But there's, the two most recent studies, they really suggest that there's a difference between the gluten sensitivity and these other people. And it has to be proved by challenge.
I mean, what's interesting is a lot of these patients can point to almost a specific month they started having issues. I mean, they're not born this way, so it makes you wonder if there's some viral insult or something that, I don't know, flip something on it.
And they acquire.
That's a good point, though, because they do have a usual time when they said they started getting sick last year or 2 years ago.
But impossible, obviously, retrospectively to study.
Well, I get more patients coming from children's now that they have malabsorption of fructose or something else. And I don't know whether they check for oligosaccharides too, or they just check for the simple.
Right.
So, David, do you know the answer to that?
Wait, we asked you a question you didn't know the answer to?
Any of the current fellows know the answer when they test for malabsorption? Do they do any of these monosaccharides or just fructose?
They do very sugary studies in stool.
Yeah, they do sucrose.
Yeah, they do sucrose and do fructose because the congenital defects in like fructose metabolism and things like that. But I don't know about the longer chain ones. I don't think so. Not routine.
All right, well, very impressed how much data we got in 1 hour. We should probably do more journal sessions. Thank you, everybody. Made excellent presentations today.
The audiovisual system worked today. I wasn't here at the beginning. I mean, was there
No, I
a
think
challenge at the beginning?
No, it's been working consistently.
Oh my God.
Yeah, just all we had to do is change
No
rooms.
more excitement.
Change
Right,
rooms.
this format is not mail that came to you, it's mail that came to our house.
Oh, sure. I'll give it to Matt.
Yeah. And
I'll put it on the
overseas,
so
yeah.
you got a couple more weeks before this.
I looked to see if we did it last year. I know we didn't do it last year, so it had to be 2 years ago. But this is just a group of patients that's really frustrating. So, I mean, I don't know what to do with them. Because they've already figured out.
Following their diet.
Yeah.
Already figured it out.
I think I have to just do that.
They usually figure out what they tolerate.
So they go off the diet and whether it's double blinded, I mean, you can't really do that in the real
I
world.
saw a guy just yesterday, he says he's lost 50 pounds, he's the healthiest he's been in decades, and he's a straight shooter.
I
just
think
normal
that's a big
person.
part of it. It's sort of like a paleo or a South Beach. They actually feel so much better because they have more energy. And it's like, why would I go back?
Or the chronic yeast people, because basically they take out.
Yes, yeah.
So,
Candida,
the Candida.
placebo, but it's an idea.
So,
And the fact that all these
on the west
IBS
side
people,
of
they find out that they get
years
better
ago,
on
they used to
gluten-free
do
diets.
bath
Our GI people don't do that. They just sort of supplement them. So maybe what we do in the testament find there's
But
nothing
now
wrong
it's a
with
small
it.
theater company. So
Right.
anyway, the
Yeah,
show
I just
called Bad
literally
News,
downloaded a
which had
quick
been
text
on
with
Broadway.
his idea. And that's
We
what it
just saw
is.
this
There's
weekend.
no grains at bottom.
Fantastic.
Yeah.
If you get a chance
So-
to go,
Yeah.
it's
Are
really
there any foods that are just a strict
very
oligosaccharide or
powerful,
polysaccharide?
very
Are
well
there any
acted
pure
from
foods that you know
a
they
local
can
theater company.
do
So
that?
it's only running another